Welcome back to the third and closing general session of the 2021 PQA Annual Meeting. But before we start our program, I am here to remind you of the discount that you, as all meeting attendees, can get on the PQA Medication Use Quality Certificate Program. You as attendees will be able to get a 60% discount, and this 15-hour continuing education program provides an in-depth education on medication use quality and is applicable to both frontline healthcare professionals as well as those in administrative roles. Use the code #2021AM in PQA's Education Center to receive this discount. So make sure to check it out. All right, are you all ready for our closing general session? Me too. But let's hear from two of our sponsors before Micah starts his conversation about value-based care.
When you partner with PQS using Equip, your business can access pharmacies nationwide to support improvement of member health outcomes and reduction in overall member costs of care. Target your members and their disease states through the use of quality measurement. Choose from a full library of PQA and NCQA endorsed measures, including PDC metrics like cholesterol, diabetes, and RASA PDC, and measures addressing therapeutic categories like asthma, diabetes care, behavioral health, specialty pharmaceuticals, opioid use, and vaccination status. For more information, please reach out at info@pharmacyquality.com or contact Emily Endres, our Vice President of Client Services, at endres@pharmacyquality.com.
Humana is committed to helping our millions of medical and specialty members achieve their best health. Our successful history in care delivery and health plan administration is helping us create a new kind of integrated care with the power to improve health and well-being and lower costs.
Good afternoon and welcome to the closing session of the 2021 PQA Annual Meeting. We're going to close out this year's meeting with a discussion of value-based care. There's increasing recognition that medication use, medication services, and pharmacist-provided care are important components of value-based care that improves patient outcomes. The pace of care transformation and the pressure to embrace value-based care are picking up, but we've just scratched the surface when it comes to optimizing medication use and leveraging the expertise of pharmacists in team-based care. To help us explore recent developments in value-based care, the role of pharmacists, and what's next, I'm pleased to introduce two leaders from the health plan and medication management space. Our first guest is Dr. Shah, founder and CEO of MyMeds, a medication management company that combines pharmacy, consumerism, and digital health to allow people to easily learn about their meds and get more engaged in their health. Our second guest is Martin Burruano, Vice President of Pharmacy Services at Independent Health, a not-for-profit Western New York health plan. He oversees the pharmacy benefit commercial, Medicare, and Medicaid and self-funded lines of business. We'll take questions from the audience later in this hour, but feel free to drop questions and comments in the box as we go. Raj, I want to begin with you. For many years, you've been talking about pharmacists and patients as just the new disruptors in healthcare. What have pharmacists brought to the care team that was previously missing?
So thank you, Micah. Nice to see you, and I'm glad to participate today. It's hard to believe it's been 6 years since I did that TED Talk. And one of the key factors is that the disruption's finally happening. And the important thing of what pharmacists are doing to disrupt healthcare today and how it's different and what was missing before is they're bringing their knowledge of medications. You know, just like I'm a kidney specialist, pharmacists are the specialists in medications. And as more people take meds, it's critical for us to have leaders on our care teams who really understand and have that kind of expertise to work with patients. And that really didn't exist before. And in the sense that certain populations got MTM, but when we really think about the fact that there are more and more people who are taking meds, more and more people who are taking multiple meds, we really need pharmacists to bring their knowledge base and their expertise to the table. And I think that's what's changing today.
How have you seen technology improve care and enable patients to work better with pharmacists to achieve better outcomes?
So I think technology is playing a role in different ways. Obviously, by enabling people with apps, or whether they're mobile or web-based, giving different platforms through the EMR and otherwise to the pharmacists themselves. But really, that connection point is happening like never before. And I think that it used to be to talk to your pharmacist, you'd have to go to the pharmacy. Now you can chat with them on an app. And I think that's how technology is changing things. But I think more important than technology is data. And how do you take that data and do something with it? And one thing that we've always had access to data, but real-time data is something that is really going to change the world. And when we're thinking about better outcomes and value-based care, better outcomes are achieved when you change people's behaviors around their health, because we're talking about people who have to take a lot of meds. And in order to be well, they have to take those meds, just like diet and fitness. And if we can enable pharmacists, physicians, other care team members with data at the right moment, that's how you impact better outcomes. And if you remember, my background's cognitive psychology with a focus on memory. And with that comes a whole bunch of focus on behavioral change, not for the short term, but the long term. And I think that right now, with the data delay of 30 to 60 days on average from the time something happens to the time a care team actually does something, that you lose a lot. And I think that the real-time data gives people the opportunity to intervene at the right moment. And we're seeing that with the ability to get more data at the right time.
So Marty, to that end, at Independent Health, you partnered with the Pharmacists Association of Western New York, really to bring the pharmacist into the fold to improve medication adherence and also work on improving health outcomes. Can you tell us a little bit about that program, why you engaged pharmacists and what kind of results you've seen?
Sure. And going back to what Raj said too, a lot of it had to do with getting them the data and getting them the data quickly. So we, as a local regional health plan, we had the kind of unique ability to be able to work collaboratively with some of our, community pharmacies, and in particular, independent community pharmacies. So we had established relationships with them over many years. As a matter of fact, I'm on the board of directors as well as another pharmacist at our health plan on the board of directors of the Pharmacists Association of Western New York. So we had those close relationships, and we knew that those pharmacies were very engageable, and they were looking to utilize more clinical knowledge and expertise with their individual patients and looking for a platform to do that. So we established a collaborative team at Independent Health and with the Pharmacists Association of Western New York to develop a program and implement a program, bringing the community pharmacist into it and providing the community pharmacist with actionable real-time data, patient-specific to their pharmacy, of gaps in care that we were looking to close. And in particular, the Medicare Star measures, HEDIS measure-related gaps, mostly quality type gaps. And what we did was we established a separate payment outside of their normal reimbursement for that. So we would provide the specific gaps. The pharmacists would report back to us specific interventions, meaningful interventions. We would pay them for those interventions. And then if those interventions resulted in a positive outcome, patient became adherent, they were introduced to statin, so on, we would pay them an enhanced payment for that. And so the pharmacist was incentivized to do that and to pay for the time, to more than pay for the time that it took them to do it. And the advantage of the health plan was these were mostly patients for which we could not reach for various reasons. They wouldn't, those members, because we're the health plan, maybe they didn't want to engage directly with us. But the pharmacist had, in many cases, a trusted personal relationship with that patient. So they were able to counsel, speak to that patient. The patient had that trust in them, so they can explain the why they needed to take these medications and the long-term outcomes and so on. So that turned out to be extremely successful and helped really augment our quality measures in a very positive way. And we're continuing with this program to this day.
So you both have described a value-based arrangement that improves patient care and puts the pharmacist into focus on this process. What's needed for this to become more of a standard of care? And so what does pharmacy need to show to be more integrated into value-based care design? And I guess we'll start with Raj first on that, and then Marty as well.
So this is something I talk about every day right now, because value-based care is the future. And what Marty just described is going to be the future, but a lot of it comes back to the human element. Digital plus human is how we're going to change the world, right? Because digital is the world in which we live. You got to give people an experience that they're used to, like banking and retail. And healthcare is slowly but steadily catching up. But that human component, that trusted relationship that pharmacists bring, when you think about surveys and what people say, pharmacists are always in the top 2 with physicians of who are the most trusted people in healthcare. And I think that is a huge part of where pharmacists come in. To answer your question about what do they need to do, what does pharmacy need to do? What does pharmacists need to do to really drive this? And Marty's the payer here, so I can pick on him just a bit. At the end of the day, it's ROI, return on investment. And I go back to 6 years ago when I did the APHA keynote. Someone from Kaiser came up to me afterwards and said, we really want to incorporate pharmacists because this is really important. And what you're saying is important, but they're really expensive. And I just said, what do you budget? And it was $150,000, $200,000. I'm like, that's 10 hospitalizations. One pharmacist can easily save you 10 hospitalizations just by interacting with a certain population you have. So your ROI is easy. And they're like, we never looked at it that way. And I said, that's where you have to think about it. You got to spend a little money to make a little money. That's just the way it is. But if you think about value-based care, I go back to what I said before. The medication experience is foundational for success. Value-based care, by definition, is focused on the people with chronic conditions. The people with chronic conditions are the ones driving the huge costs that we're trying to curtail. And the only way we're going to do it is by making them healthier and have better outcomes. And everyone focuses and talks about diet and fitness, but we all know that's hard to do. So you need meds in order to achieve that goal. And when you recognize that medications are critical to getting people to take their meds properly, that's critical to improving health, which is critical to changing behaviors, which is critical to value-based care being successful. So it's all tied together. And the thing is, people are starting to understand that pharmacists play that critical role in that medication experience. It's still early, but when you have Marty and Independent Health doing the stuff that he just talked about, that's the future. When you think about companies like DocStation that are empowering pharmacists in the same way, I think that's how we really need to get beyond filling pills, giving vaccinations as a first step, but really demonstrating that ROI to the financial team. And within health systems, getting a physician champion involved, because it's the team-based approach that's going to really win.
So Marty, what do you believe is needed for pharmacists to really become more of a standard of that healthcare team that Raj just mentioned?
Yeah, and Raj was right on. It's all about value for a payer. So the question arises then, how do we demonstrate that? How can we demonstrate value for the physician provider? How do we build a team of teams with the pharmacist as an integral role in that team of teams? So we, again, being a local payer, we have established trusted relationships with our community providers, our PCPs. And this has been over several decades, right, that we've developed these relationships. So our providers are engaged and have been early adopters to starting to see the value of a pharmacist within the practice, or utilizing health plan resources for pharmacists through MTM services and so on, and acting on those recommendations. But so many of our large clinical practices in the Western New York area have pharmacists embedded in those practices. And as a result, we established a clinical provider engagement team at Independent Health, made up of clinical pharmacists working directly with those practices. Again, providing actionable data, providing the gaps in care directly to the provider's office through the pharmacists act on those. And they really make quick changes because the physician trusts the pharmacist to make those changes in the practice. So we have value-based agreements with these providers, which involves total cost of care. So providers see the value in lowering the pharmacist's ability to impact lower cost of care in what Raj, lower admission rates, lower ER rates, healthier patients, and so on. But also, we wanted to go a step further and show, based on the salary alone, on a pharmacist's salary, can we justify to that office, really, very simply, the pharmacist's salary, even independent of those things. So as a secondary endpoint, so we got the clinical and then just the cost. So we established outside of their value-based arrangements, we actually established some LOAs, letters of agreement, with those practices with embedded pharmacists, and actually paid them an enhanced payment for the interventions on an intervention basis, like we did with the community pharmacies. We did that with the embedded pharmacies as well. So then we paid them an intervention payment and an outcome payment directly based on the pharmacist's intervention. So the physician could visually see the check going to that practice for what the pharmacist did, justifying that salary alone. And then in addition to the ROI that they're seeing as a result of their MTM interactions, their gaps in care closures, and then the advantages on the medical side due to less drug misadventures, for example, and adherence. So that has really been a win-win for us, payer, win, and the patient ultimately in driving, in positively impacting quality and cost. And as you know, quality over cost equals value. So that was our end in mind.
So I would be remiss if I didn't ask two thought leaders and innovators in this space to look into your crystal ball and look at the future. And what does a more optimized healthcare model look like, both in terms of value-based care and incorporating the pharmacist into the fold? So as you work to build out your new innovative model for care and digital health engagement, specifically in those areas, what does this perfected model look like to you? And in 10 years, when we sit down and talk about this again, what do you hope to achieve? And we'll start with Marty and then wrap up.
First, we have to address the barriers, and Raj actually spoke to some of them. As far as we need to make sure they've got actionable data, they've got the internal resources too. We didn't really talk about that, but we also work with our primary care practices on office workflow management. So whatever they do has to be within their workflow. They don't have time to work outside of that. So Raj mentioned EMR, right? So having these gaps of care actionable data available through their EMR in a push rather than a pull too. And then also having sufficient technology built in for them to be able to pull that basically in real time and act on it effectively. What we're seeing for the future is, I think we're going to see, and we're starting to see it already, is this is going to be a standard of care. I really believe that, with the pharmacist as an integral piece of the population health multidisciplinary team approach, working collaboratively with physicians, nurses, nutritionists, social workers, whatever, especially targeting, specific populations. You're chronically complex, right? Pulling those patients out, making sure you're working on targeted populations, and the pharmacist being an integral piece of that for MTM services, adherence programs, even home visits for those patients that may need it, and so on. And thinking outside the box, what are we going to do in this team of teams or multidisciplinary approach to maximize the value of the pharmacist? And I think we're starting to see that.
What about you, Raj? What does the future look like?
So I can give you two examples because I still practice nephrology. If I put both my hats on as a nephrologist as well as an entrepreneur, I think two things. One, when you look at what is the ideal situation, and kidney care is a perfect value-based model because the whole idea is how do we keep people off dialysis or transplantation by preventing and slowing that progression, right? In the end, it's the only way to do it is medications. And so that's where I would look at, let's say a patient comes to see me and they've got early stage 3 chronic kidney disease, right? The diabetic, high blood pressure, and a little bit of protein in their urine. So the first thing I'm going to talk about when I meet with them is explain chronic kidney disease. You're not going on dialysis tomorrow because they're all freaked out to see me to begin with. And then talk about the importance of meds. So the physician has to start the conversation because that's where the immediate trust is. But then saying, all right, in my office, I have a pharmacist here and I'd like you to meet with them because we've got a little bit of time here to go through everything, but I'd really like you to focus your time and meet with this pharmacist to really understand each of your meds and not just what do you take and what it looks like, but here's what it is, here's what it's for. Because when people understand what they take and why they take it, and then they get education that, okay, I take atenolol, it's for my blood pressure, controlling my blood pressure prevents a heart attack or stroke, and I don't need to go on dialysis. Now it's important to me. And when you are trying to change behaviors, you have to make it important to that person. It's got to be personalized. And so by having that pharmacist go through and teach them, at MyMeds, we call this our YMeds technology, which is, what do you take? Why do you take it? Here's what could happen if you don't, and controlling your condition. And then here's the picture of the pill. So it becomes this model and this habit that you get in your head. And that's, again, when you personalize it, you change behaviors. But having that pharmacist embedded in the clinic for that up is important. And then checking in remotely, you could send texts, you can set up a video session for 15 minutes every few months just to check in from the pharmacist perspective. And then they see the doctor on their schedule. If it's someone with stage 3, I'm only going to see them once a year. But I'd like that pharmacist to check up quarterly just to make sure that they're taking their meds. And it's all empowered by data. And so if you have PBM data in real time, it's really important because PBM data is different than EMR data. And I hate to say this, but almost all the time, the EMR med list is wrong because that's what I prescribe to you and I put into a computer, but it doesn't necessarily mean you picked it up. It doesn't mean you got it on time. And that's where that PBM data really becomes valuable because we can see when did someone fill. Okay, if it's a 30-day prescription, did they fill within 30 days or did they fill on day 36? And it's those kind of gaps and that actionable information that really will change it. So again, the ideal situation is you've got your physician-patient relationship. You bring in a pharmacist-patient relationship. That pharmacist becomes an intermediate relationship in between. You get data to the patient. You give them tools that help them understand easily. Because at the end of the day, if it's hard, they're not going to do it. And it has to be, a user interface that they'll use. And then just empower it with real-time data. And I think that's the future. And if we do that and do it the right way, that's how we're going to impact people with chronic conditions. That's how we're going to change value-based care. That's how we're going to lower total costs of care. And it's a multi-win situation for the payer, the provider, the pharmacy, the patient, who in the end, that's all we care about or should care about. So that's my ideal for the world.
I certainly look forward to working with both of you in the future to achieve that vision and those goals. Marty, Raj, this has been a great discussion. I'm looking forward to hearing from our audience on the questions and answers. But before we take live Q&A, we're first going to hear about an innovative pilot that's demonstrating how pharmacies are playing a key role in managing patients with diabetes and improving outcomes through value-based care.
All right. Hello, everyone. Thank you for the opportunity to share with you today. My name is Sarah Shetler, and I'm the clinical pharmacist lead for the Quality Network at Humana. Today, I will be presenting with Emily Endres from Pharmacy Quality Solutions and Andrea Brookhart from Kroger to discuss a pharmacy-led A1C management program Humana designed and then piloted in 2020. As a health plan, Humana seeks to approach member health holistically and create programs that provide a positive member experience while engaging all members of the healthcare team to improve clinical outcomes. We believe that pharmacists offer the accessibility, clinical expertise, and patient and provider relationships that are crucial for successful condition management. And we know pharmacist-led interventions have proven benefit in diabetes-related clinical outcomes. This is particularly demonstrated in the ambulatory care setting, but we expect this can hold true in the community practice setting as well. Humana recognizes the ability pharmacists have to address multiple quality measures focused on diabetes outcomes, including the HEDIS and Medicare Part D STAR measures for A1C control, eye exam, kidney disease monitoring, medication adherence, and statin use in persons with diabetes. Pharmacies already are responsible for managing diabetes medication adherence and statin use, but have historically had limited opportunity to impact other disease-related outcomes. So for this pilot, we provided pharmacies the visibility and opportunity to address quality measure performance through PQS Equip platform with the hypothesis that displaying quality measures for A1C performance providing essential lab values, and incentivizing interventions for members failing to measure would increase pharmacy engagement and close clinical gaps in care. And so with that background, I will pass it along to Emily from PQS to share additional information regarding the program structure.
Great, thank you, Sarah. At PQS, we continue to be incredibly excited about partnering with Humana and our participating pharmacy network in support of this first of its kind A1C outcomes-based pay-for-performance program. We couldn't agree more with you, Sarah, and Humana's perspective regarding the pharmacist's ability to influence patient behavior and the increased opportunity they have to monitor a patient's progress. Enabling pharmacy in a way in which allows for additional new reimbursement models beyond the product and specifically for disease state outcomes is a part of our mission and vision at PQS, and we're proud to support opportunities like this program, which focus on patient outcomes for A1C. To support Humana's goal in standing up a pilot program, PQS played a couple of key roles. Primarily, PQS' role was to provide quality measurement as the foundation for both the pharmacy and Humana to understand pharmacy MPI and patient-level performance using our measure platform, Equip. And one of the key drivers for success in an outcomes-based program is having access to all the right data at the right time. And through an enhanced level of data sharing with Humana, Equip was able to provide pharmacies with valuable medical and lab claims data needed to support patient conversations so pharmacies could have all of the pieces to their patient's A1C puzzle and use those data points to best counsel and support their patients towards success. Now, our secondary role in this program was to provide the health plan with a pharmacy network that was large enough and flexible enough to support specific targeted patient populations. With over 65,000 actively engaged pharmacies, we were able to deliver this opportunity to a wide array of community pharmacies ranging from chains, grocers, and hundreds of community independent pharmacies, all of which were very eager to participate in this outcomes-based pay-for-performance program. Now, as mentioned, the PQS platform Equip served as the data facilitator in this program. And as you can see to the far left, we displayed two measures to help pharmacies track their progress in the program. And those were A1C testing and A1C under control. Next, we displayed the number of patients, or the measure denominator, which is 12 in this example. And you'll also notice this number is the same for both measures. And this is intentional to ensure the program is following the same population through the different covenants of disease state management for A1C. Equip users are also armed with their performance scores measuring the percentage of patients who have met the intent of the measure. So in this example, all 12 patients had engaged with a provider to receive an A1C test, and 25%, or 3 out of those 12, had an A1C which was less than 9%. And the program goals are displayed next to that performance score to help set the sights for the program. And then all the way to the far right, you see that users are also provided with additional organization and state level benchmarks to help understand how their performance measures up against their peers. So now in that third column from the right, we see the gap column. And this is where pharmacies are able to drill down into those really critical patient level details. When pharmacies click on the outliers button, as we saw on that previous slide, they are taken to this next page in Equip, which provides additional patient details necessary for success. Equip is able to show pharmacies when and where the last A1C test was performed, and most importantly, the value of that last A1C test on file, so that pharmacies can understand the level of improvement required to bring the member into range. Now, these data points help to align intervention and counseling timelines for the pharmacies. And because these elements are updated on a weekly basis, pharmacies are able to readily track their patients' progress. Now, lastly, and as a program requirement, pharmacies were asked to document their encounters with the patient by completing a very short list of questions designed to help Humana understand what type of intervention was performed and resources used in the intervention process. This data was then shared back with Humana and used to best understand how the pharmacy's intervention efforts help to deliver the desired patient outcome. Now, with that said, I will turn it back to you, Sarah, to dive more into the program design and success details.
Thanks, Emily. This program included about 10,000 members in 6 states, those being Iowa, Texas, North Carolina, Kentucky, Arizona, and Ohio, who were a part of the experimental group. And these members were attributed to about 650 pharmacies across those states with a mix of varying size regional chains as well as independent pharmacies. To be included in the program, participants needed to be enrolled as a Humana MAPD member and also qualify for the NCQA HEDIS Comprehensive Diabetes Care Measure. Members targeted for the intervention at the pharmacies were those with an A1C testing gap and or an A1C control gap in care, meaning that they had not completed an A1C test in 2020 and their results were considered out of range. We did refresh member eligibility weekly throughout the program, so new members were provided to pharmacies and added as they became eligible for the Comprehensive Diabetes Care Measure throughout the year. And lastly, we provided value-based reimbursement utilizing a tier payout of per compliant member for pharmacy NPIs who achieved the desired A1C control measure performance outcomes. The program ran from mid-June through the end of 2020, and we found that 20% of the eligible members were enrolled and 62% of eligible pharmacies participated in the program, meaning that of the 10,000 eligible members, just over 2,000 had disposition data documented in the Equip platform following an intervention with the pharmacist, and just over 400 of the pharmacies eligible documented at least one intervention for members. Though this does leave some room for increasing future participation with more members at additional pharmacies, I want to call out that we did launch this very early on in the pandemic, so we are really appreciative of the pharmacists who made this program successful amidst many other changes that were going on in their pharmacy. Pharmacists proved that their value in closing an A1C gap-related care in this innovative model and demonstrated the agility and receptivity that when we provided additional medical data and opportunities for enhanced clinical care, they could perform well. Across the program, we found that this work produced a statistically significant increase in both A1C test completion as well as A1C control performance compared to our control group utilizing a categorical outcomes testing model with a chi-square test in which p-values were proved to be less than 1/10,000. So at this point, I will transition to Andrea from Kroger to share about her pharmacy's experience with the program.
Thank you, Sarah. At Kroger, we were really excited to be able to participate in this program to receive additional data about our patients so that we can help improve the health of that population. Our participation did look a bit different than what was described in this program, which speaks really to the flexibility that PQA offers, or PQS offers, in providing data to its network of pharmacies to be able to best serve the needs of that population. So what we did was we would use that data provided to us and take it into our patient care services queue, which is within our pharmacy dispensing platform. This enables us to present all of the work identified for our patients in one place and still present those critical patient level details seamlessly for our pharmacists. So first, the patients who were eligible were identified, and then we would populate those interventions that we were recommending to be completed within that patient care services queue. Then our pharmacy teams would perform patient outreach, pharmacists would provide customized counseling to those patients and try to close whatever gaps in care we were elevating within that queue. Then our documentation occurred and we provided that data back to PQS to enable them to close the loop with Humana. And the different types of interventions we provided throughout this were kind of selected within our own group. And what we offered were our general population health management programs. These are things like adherence interventions and gaps in care interventions that we've offered over the course of the last 5 years within as a standard of care for the populations that we're managing. We also offered focused interventions for A1C test reminders, diabetes education on standards of care. And then we also leveraged a diabetes targeted medication review, where our pharmacists would specifically review the medications associated with that patient and recommend changes, if applicable, to help improve their A1C control. We saw a great level of completion across the board with these different types of encounters. And we've had really some success stories, which one I'd like to share with you. Throughout this program, a patient had been identified with an A1C of 11%. And our pharmacist recommended that the patient enroll in a refill program because they figured out that they often didn't come and pick up their medications on time and went without their medication for a period of time. They also counseled on the use of the medication that was not being used correctly by this patient, which in this case was Trulicity. Over the course of time, as we saw the different documentation provided by that pharmacist, we saw that the A1C noted for that patient decreased to 8.5%, which really speaks to the improvement that can be made through pharmacist level encounters. And the patient was also noted to have received all the indicated vaccines for them, given their disease states and age. And they had also participated in all of the preventive health visits recommended to them because of that diabetes education on standards of care. So I think it really speaks to this program and the ability of pharmacists to help improve patient outcomes by just giving you one story from one patient, which was frankly one of many. So I learned through this program that we could continue to use this patient level data and take that into our pharmacy dispensing system to help improve the health of a population more meaningfully, because we have additional medical details that we wouldn't otherwise have access to from pharmacy claims data. And with that, I'll pass it back to Sarah to talk about other lessons learned.
Thanks, Andrea. So to conclude, I would like to sincerely thank PQS, Kroger, and all other participating pharmacies for their work to make this program a success, and note that Humana is really eager to continue paving the way in this type of pharmacy innovation and partnership. We demonstrated that pharmacists, when provided visibility into medical data and given opportunities for documentation and reimbursement, as Andrea stated, can improve performance for A1C test completion, as well as A1C control, and play a vital role in the holistic management of diabetes at a pharmacy level. So with that, I'll thank you for your time, and we look forward to taking your questions.
Well, we're excited to have our esteemed guest here to answer a few questions from our audience. So I'd like to welcome Andrea, Emily, Sarah, Marty, and Raj. Welcome. The first question we have is for Dr. Shah. You spoke about healthcare catching up to new industries when it comes to digital utilizations. What are some of the barriers you see to faster adoption of digital solutions?
So I think one of the biggest barriers to adoption is security and making sure we get through all the enterprise security, because I think what happens with healthcare data and healthcare experiences, everyone's so concerned, as we should be, about that. But when you make it harder for individuals to log on and the multiple passwords and all these things, it just really interferes with the adoption. When it comes to actual using of the tools, a lot of it goes back to recognizing that who are the people who have chronic conditions, who are the people who use technology. And there's this big movement to app only, but app only works for people who use apps. And when you think about the fact that 70% of Americans do healthcare on web-based tools, either a computer or a tablet, 20% will go back and forth between a computer, tablet, or a smartphone, but only about 7 to 10% are smartphone only, and they tend to be the younger age groups. I think we have to recognize that we're designing tools for the right people. And so I think those are generally the biggest barriers to adoption.
So, Marty, does Independent Health have any publications describing the value-based model and health outcome savings, press releases, scientific publications? What evidence is out there that you all have?
Yeah, actually we do on the pharmacist, and the Pharma Association of Western New York program that we perform with our community pharmacists. We do have a publication that we did. And also, I forgot to mention in the talk that we also did this in conjunction with the University at Buffalo School of Pharmacy as well. And worked on a publication with the School of Pharmacy. So I can definitely provide that information for you. We haven't published anything on the provider side as far as the embedded pharmacy within the practice and the value-based model. We haven't published anything in that area, but I do have outcome data that I could share.
Yeah, and outcome data is always welcome, and certainly appreciate that, and we'll try to get that up on our website after you provide it to us. So this next question is for Andrea, Sarah, and Emily. Your efforts are focused in the community pharmacy environment, which is a great practice setting with many opportunities to meet patients where they are. Have you evaluated the feasibility and scaling of this project across all your pharmacies, and what more is needed to scale this project up further? We'll go with Andrea first. I'll pick on one of the squares first.
Sure, thank you. We have largely evaluated the impact of putting this into all of our pharmacies. And we, Kroger Health, have really taken the stance that every pharmacy team is going to be equipped to provide clinical services across the entire enterprise that we have. And we've been really intentional in those choices. We've provided kind of a level set training several years ago now that I was lucky to be a part of, and we've kind of scaled up from there. So the fact that we offer these types of services by embedding them into our patient care services queues, which is embedded within our pharmacy system, makes it really easy for our associates to engage, to have role-based task completion, meaning the right people are doing the right work, and that we're serving it up at the right time for our patients to engage. So that makes it really approachable and enables us to really be successful with those types of programs.
Emily, Sarah, thoughts?
From a peer perspective, I would say one of the real advantages of this program is working together, like able to standardize across different pharmacies. We try to manage the intervention best successful member, whether that be telephonic call from a local pharmacy or maybe a face-to-face. Certainly want to continue to expand in partnership with community pharmacies like Kroger or others, maybe even right there or something.
Well, how about you, Emily? Talk about scalability. I know you have a lot of opportunity at PQS, so you want to share a little bit about that?
Yeah, absolutely. We are starting to see some increased awareness around these types of value-based care opportunities for community pharmacies. And when we think about scalability, PQS, we're well positioned to provide that scalability across our health plan and PBM partners, and certainly across our network of 65,000 plus community pharmacies that we help to partner with and kind of bridge that communication gap. I think, Dr. Shah, you mentioned it earlier in this session, just the importance of data. And we've all kind of spoken to that aspect here a little bit throughout our portion of this session here. And it's so incredibly important for team members like Andrea and all of your team members at Kroger, in the pharmacy arena in general, right, to have the right data at the right time. So scalability definitely means having access to medical claims data, lab claims data, certainly pharmacy claims data, to really help create that picture that's necessary for success when we think about these value-based care opportunities for community pharmacy. But scalability through the platform and dashboard is certainly our forte, and we'll look forward to supporting these types of opportunities here in 2021 and moving beyond.
Well, thanks for addressing those questions. I think that's something that's on all of our minds, is kind of how do we ramp up some of the testing efforts that we have with Community Pharmacy Foundation and the community pharmacy measures that we're looking to stand up, and this is a great example of how that can work. Are there plans to expand the pilot with other disease states?
Right now, one of the major focuses is diabetes. We are looking to expand within that disease state at this point for 2021 is to include an eye exam measure, and ultimately I think we want to be able to take more comprehensive like blood pressure, nephropathy, other diabetes considerations. And then from there, you also need to positive value and definitely let's do what we can to leverage pharmacists to address multiple. Cardiovascular is always one that is high in this diabetes. There, given a positive perspective from pharmacies and from members, the sky's the limit.
Well, it brings up an interesting discussion. We have a lot of different focuses in a lot of areas, but it seems to be that blood pressure, A1C, cardiovascular, those are the disease states that we struggle with a lot. So we have to focus on those first because those are the most prevalent. And so focusing on those certainly makes a lot of sense. And especially as medications drive so much of those outcomes, those positive outcomes, it makes sense to mirror that with medication use and quality. So for the Kroger Humana PQS pilot, did the team notice any differences among the disparate geographies included in the pilot that might indicate the need for targeted approaches for some populations?
So I don't know if Sarah wants to speak to that overall for the entire project, but I guess I'll just share some more anecdotal commentary for us because we are a nationwide chain of pharmacies. We do see marked differences in the performance on quality measures in different geographies or even just within localities. So we attribute some of that to social determinants of health and the impact that those type of socioeconomic factors and other factors impact the ability for people to access care, have to make choices between, picking up groceries or purchasing food and purchasing their medications. And so those are things that we are trained to, deal with and provide some of those breakdown barrier options to people as we try to provide increased access to care and evaluate how we can best help our patients and support them on their journey to a healthier life.
And to Andrea, to that point, I think we've heard some really good models of organizations that are looking toward improving those social determinants of health and addressing them through these types of programs. So I know there's going to be a lot more work in the future, and it's something that PQA is committed to, and we appreciate all the focus on that. Can or has telehealth been utilized by pharmacists in any of your models of care?
I know at Independent Health we have not utilized pharmacists in that area yet.
So opportunity for the future.
Correct.
And kind of a follow-up to that on technology, and this may be another thought-provoking question for the future, but the use of technology is fantastic for those who can be reached. Are there any plans to focus on increasing the use of mobile health and technology-first solutions that may also systematically leave out especially vulnerable patients? And Raj, I think you spoke a little bit to this, is targeting the appropriate technology to the appropriate patient population and how they like to be communicated with. So how do we keep those patients in mind if we're targeting technology solutions toward certain populations, certain patients that may not have access to that type of resource?
So I think one of the ways to do it is not only to target the patient, but also the caregivers, because a lot of the people who are left out of technology, especially the newer technology, tend to be older, but yet they have younger caregivers in their families or elsewhere who are helping them. So if you can target the caregivers as well, that's one way to get around it. The other part is just, again, understanding the population. For example, a lot of people think Medicaid patients are not tech savvy, but when there's an organization called Health Tech for Medicaid, H4TM or HT4M. And, what they've shown is that Medicaid users have almost the same tablet usage. It's more Android versus iPad. Similar mobile usage. Medicaid is much more likely to text because you can buy the unlimited text program for $5. And so I think that if you understand your customer, you're going to be able to build the right technology for the right people. But I think the big thing around the people who are being left out is making sure we recognize that caregivers play a huge part of the healthcare world and growing, and we need to make sure that they're enabled as well.
That's an excellent point. Because care is so much focused on not just the individual, but the people that are surrounding the individual and supporting them. So, Andrea, one of the questions that came in was, how did the pharmacist promote A1C testing? Was it point of care testing at the pharmacy, or was there another type of situation that you all worked with?
Yeah, we were promoting testing that was actually offered through the Humana program. So Sarah would probably be better to speak to that particular question since we were promoting the Humana offered solution.
Oh.
Sorry about that.
program, our intent really was to leverage pharmacies to provide member education and referral to their primary provider or prescriber with the hopes that they could help kind of inform that continuity of care and go back to their provider, especially if they've not continuously. We also leveraged our at-home testing structure, so we didn't have an alternative where members could listen to at-home testing, which was really important this past year, and we implemented and the pharmacist extension plan helping them work forward when you're on our forefront and priority.
So regarding the pilot, how could this be translated into a standardized and feasible measure for plans for pharmacy value-based arrangements? And this may
I think at least from the
go ahead.
From the pharmacy perspective, we're eager to start to be contributing to and evaluated on these types of measures that are more based on the medical data or the medical side. We need to continue to have partners like Humana and PQS who are able to help equip us with the data that we need to support providing that kind of care, because pharmacists are certainly equipped to close those gaps in care, to provide A1C testing. We should continue to focus on building out our capabilities regarding pharmacist e-care plans so that we can integrate those types of data into other provider EMRs and back to plans in the form of documentation. So we're certainly on that path and eager to participate with any willing partners. And I think this is a good step to demonstrate that it's feasible.
And I'll just add briefly to that, Andrea, I couldn't agree with you more. And I think that standardization piece is wildly important, right, for adoption, engagement, ease of interpretation on the pharmacy provider side as well. So using quality measurement as the foundation and a vehicle to move these types of value-based care opportunities forward, I think is really imperative. That coupled along with the real-time data, again, having access to all of those key data elements. And you talk about the test kits, or if it was really point of care testing, et cetera, those are even data elements that were provided to the pharmacies within this initial pilot program. Where was the test kit mailed to? When was it shipped, et cetera? So really utilizing that kind of standard measurement platform, again, as the vehicle to deliver all of those critical data elements, it will be crucial in moving these programs forward and being successful in the programs.
And I'd just like to add to that, because I enjoyed hearing about the Humana's A1C program very much. And most pharmacies are willing, they're very willing to engage. So it's an opportunity that's asking, it's in the asking, they're eager to do this. Pharmacies' business models are changing. They're looking for alternate reimbursement mechanisms around quality of care. So this is the time to really start and continue to promote and build these kind of programs into that very accessible resource.
Well, that's all the time we have for questions this afternoon. I want to thank all of our participants on the panel, Sarah, Emily, Andrea, Raj, Marty. It was a pleasure. Thanks for joining us, and thanks for participating in the PQA Annual Meeting. It's a pleasure.
Thank you.
Thank you.
Thank you.
Wait, Micah.
Hey, Lauren.
We have a few questions from the audience, and all from the audience here. So thank you to our panelists for joining. I'm sorry to abruptly interrupt your session. You ready for your questions?
Sure, Lauren.
Okay, all right. First question, what have you enjoyed about your first PQA annual meeting as CEO?
I've really enjoyed interacting with all of our members. It confirmed a lot of what I knew about this organization, but being able to provide some face time with our members has been one of the most rewarding things that I've seen. I can't wait to see you all in person, but virtual is the next best thing.
Oh, good answer. So with the second question, what are you most excited about for the remainder of 2021?
Oh man, let me think about where I want to go with this.
This is the answer.
I am most excited about the PQA Leadership Summit, November 10th and 11th in Arlington, Virginia, live.
Yeah.
Lauren.
No.
Did you edit out my middle segment?
No, Richard. No. Back to our questions. Back to our questions here. So what Dolly Parton song would be on your soundtrack for life?
Oh, I think without a doubt, hands down, 9 to 5.
Okay, you have to explain that one.
9 to 5 is about.
Can we go now?
It is about time to go. Well,
okay.
Join us for the PQA Research Symposium and poster on Monday. So we'll see you back on this online platform for that Research Symposium and poster session. Fill out the online meeting evaluation form. Claim your continuing education credit by June 11th. And like Micah said, mark your calendars for the PQA Leadership Summit, November 10th and 11th in Arlington, Virginia. And thank you for attending the 2021 PQA Annual Meeting. Thank you for being part of the Pharmacy Quality Alliance. And it has been our pleasure to host you this week, and we'll see you back on Monday.